So there's the atria, right, in the top chamber, and there's the ventricle, and in between there's a little thin strip
Hmm.
of conduction tissue called the AV node. And in there, I mentioned short circuits. So sometimes you can have short circuits in there, or you can have short circuits called bypass tracks in that
Hmm.
kind of thin demilitarized zone between the top and bottom chambers of the heart. The rhythm that you feel there is you're just sitting there. And it's like the all of a sudden, doc, I just felt my heart buzzing in my heart, in my chest. The speeds of the heart can actually give us some sense of what the rhythm is, right? When you're getting past 160 into that 160 to 180 kind of 200 zone, generally that's going to be some sort of a supraventricular tachycardia or a bypass tract. So there's, again, a lot of different ways that we look at this, a lot of different inputs that we get.
Let's start with palpitations. Obviously, you and I know there are things that are benign but annoying, and then
Yeah.
there are things that are more concerning. And it was purely coincidental when we were connecting that you mentioned this was an area of research that you studied during your training. So, for listeners, truly serendipitous that Dr. Sanjay and I are going to have this conversation. Let's talk about palpitations. Let's unpack why they happen. Let's start with like the benign stuff all the way to the more concerning things that are out there.
Yeah, perfect. So, and you kind of intuitively said a classification system that I don't know if I came up with, but that I'd often talk about with patients. If you can imagine a two by two kind of Punnett square or matrix, on the top, I think of arrhythmias as either fast or slow, and on the side, annoying or dangerous, right? Now, these are
Mhm.
the arrhythmias, not the patients. I'm not calling a patient annoying. Something that's not necessarily fatal or would not necessarily have consequences, but just you feel them and they just get you anxious and amped up. And so, with the framework of that matrix, we can really kind of fill out all the different types of arrhythmias and things. But before we even jump into that, let's talk about what a palpitation is, because a lot of people might not be aware. And your heart is like the thankless organ in your body. It beats 60, 80 times a minute, 60 minutes an hour, 24 hours a day, do the math. I mean, it is hundreds of thousands of times per day, but you should never really be aware of it, right? You shouldn't have to think beat, beat. Would be a big problem. You'd never get anything accomplished during your day. So we have this autonomic nervous system that drives our heart rate up and down. But every once in a while, you will be aware or you can feel a heartbeat, whether it's early, whether there's a pause, whether it just is kind of beating out of your chest. And those are the sensations when you're more aware of the heart beating that people refer to as palpitations. They can either be a single beat, they can feel like a skipped beat. They can feel like a my heart is about to jump out of my chest. So a lot of different things fall under that moniker of palpitation. But again, with that framework, fast or slow, annoying, dangerous, we can figure out what's going on. And the origin of these palpitations can come from a few different things, but generally, what's happening is there is an electrical system in your heart that starts in the top right, and then sends an impulse down to the bottom left of your heart. And anywhere along the way, you can get interruptions of that electrical system. So you can have little short circuits that cause the wiring to go in kind of a roundabout movement. We call that a circus movement, and that can fire fast, 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 fast heartbeats all the time. You can have a premature beat that starts in the top of the heart, and sends it down, and sends the impulse down. You can have a premature beat from the bottom of the heart that sends electricity up. So there's a lot of different things at play, and as a result, there are a lot of different ways that they can go wrong, and there's a lot of things that you can do to get them right. But one of the things that I realized, and I think in our last conversation we talked about that little LDL bump that you get around perimenopause. What can happen is that as we see hormonal fluctuations, that can actually affect the electrical system of our heart at a very microscopic level. And so in our hearts, inside of these wires, we don't have a little 9-volt battery sitting there, but we have pumps that are moving ions back and forth, like sodium and potassium and magnesium and calcium and all these different things. And as we get hormonal shifts, you can get dysfunctions of those pumps. And that was the research that I did 100 million years ago, in the hormonal fluctuations of these ion channels. And so it stands to reason that a lot of women around the time of menopause, perimenopause, are dealing with sleep issues and hair issues and joint aches and all these things. But one of the manifestations of that perimenopause can be palpitations from these ion channel problems that get created.
Yeah, you did such a beautiful job of kind of illustrating, how clinicians go about evaluating. And when I talk about clinicians, generally speaking, cardiology experts, how they kind of go through the algorithm in their brains as they're talking to patients. There are benign things, but annoying, and it goes all the way up to concerning ventricular arrhythmias that we never want to see. And as a former cardiology nurse practitioner, every once in a while, I would get someone, we'd have a consult in the ER, and I would be talking to this relatively healthy patient, and they'd be talking about palpitations, and they're on a cardiac monitor. So they're hooked up, and you can kind of get a sense of what's going on between the atria and the ventricles. And every once in a while, someone would be talking to me, and they'd say, that symptom that I was telling you about, it just started. And there across the monitor goes a ventricular arrhythmia, and they're wide awake and talking. And the ventricular arrhythmias, for listeners, are the concerning things. And I was like, oh, hang on a second. Let me get right back to you. So
Right
always
back.
good to have these things evaluated. In most instances, they are in fact benign. And in my clinical experience, it would be things like someone was studying for an exam, or someone had really poor sleep and they were ingesting more caffeinated beverages than normal, or extra stress, losing more electrolytes than normal. Low magnesium can precipitate, low potassium can precipitate a lot of things. And when you are evaluating patients and talking to them, what are some of your red flags? Like, okay, this is less benign and this is more concerning.
Yeah, and so where that's when you go into that dangerous bucket from the annoying. So lightheadedness, dizziness, passing out, feeling you're going to pass out or actually passing out. We call those near syncope or syncope
Yep.
events.
Don't like those.
Those are always kind of scary. Episodes, like episodic symptoms that are unpredictable. So I had a woman, a female patient, this was probably about 10 years ago, who came to me for an unrelated issue. She came to me, somebody had heard a heart murmur on her, and I'm just asking, anything else going on with your heart, any fainting spell? She goes, yeah, it's weird. Every once in a while, I just get a spell where I just pass out, and my kids are just like, whatever. And, it hasn't happened behind the wheel. And here I am, like, jaw dropped. If this was a cartoon, my eyes would be popping out.
Yep.
And I'm like, oh, okay. So you're telling me you have intermittent episodes of passing out where you can't predict them, and sometimes you're behind the wheel driving your kids. Hmm. Let's get you on a monitor. And so we put her on a third day monitor, and it was something like day 28, where she was going into something called intermittent complete heart block, where the
Oh,
top of the
not
heart and
good.
the bottom of her heart were just no
Good.
longer speaking to each other. And it turns out she had had Lyme disease, and so this was one of the late manifestations of Lyme. She never thought about it, and I was probably the fourth or fifth cardiologist that she had seen. I couldn't believe nobody else elicited that history or did something about it. And we ended up having to put a pacemaker in her, and she was young; she was in her mid 30s, but her spells went away. So I think people oftentimes will accept a lot of things as normal that are not. And so if there's something that just isn't working correctly, yeah, go get it checked out. Talk to someone who knows, because that could, she could have been of course, I always think of the worst case scenario as a cardiologist. I mean, she could have been driving a bus full of orphans off, over a bridge and fell off, how many bridges and all that stuff. But you have to think about these things as worst case scenarios. And for her to have intermittent syncopal episodes because of heart block, not great. But luckily, now she had to go through a generator change and device change because the battery wears out over time on the pacemaker. And that was like probably 10 or 15 years ago, and she's still doing great. But had you not asked the right question, she wouldn't have given me the right answer. But yeah, these things can be annoying and dangerous, I guess, sometimes too, if you don't know the right questions to ask or piece things together, right?
Well, and this is where I used to always say to students, whether it was a medical student, NP student, PA student, this is why getting a really good history is so important. 90% of what you need, the patient will actually tell you, and the physical exam is just backing it up for you, because that gives you an idea of which direction to go in. And to your point, I live in a state where Lyme disease and tick-borne illnesses are endemic. And I think the county that I practiced in when I was part of that cardiology group was the number one most reported cases of Lyme in the state. So
Jeez.
we saw more Lyme than anybody, and we would have 16-year-old, 18-year-olds in the ICU with complete heart block. Thankfully, with treatment, theirs resolved and went away. But I used to always say, when you see a young person in complete heart block, I automatically thought about tick-borne illnesses. So it really can be problematic. And kudos to you for listening to your patient and doing that event monitor so that you had a good sense of what was going on. Now, when we're talking about hormones, so like estrogen and progesterone, I know that estrogen can be involved in lengthening ventricular repolarization, and progesterone and testosterone can shorten it. So maybe speaking to what an electrocardiogram is and kind of the basics about what's going on with the atria and the ventricle so that we can kind of unpack some of this information around these particular hormones. I'm trying to learn to not say sex hormones because it then, if I say sex hormones, then people think it's just about bikini medicine. And I want people to think
Oh,
of testosterone, estrogen, and progesterone as systemic hormones because
right.
it's not just about bikini medicine, it's our entire bodies, including our heart.
Yeah, I missed out on that bikini medicine fellowship. I didn't know that was available. But I mean, you realize that both men and women have estrogen, progesterone, testosterone, right? So and I think when you say sex hormone, it kind of automatically puts you in that mind of men versus
Mm-hmm.
women or men and women. So the in an EKG, you want me to go through an EKG. So there's little
Yes.
squiggles and blips, and so anyone who's ever had an EKG, that's where they put the stickers on your chest. Generally, be a line across, starting here and starting at the kind of upper right chest and going down around the left, and then might put some on your shoulders or on your legs, and that generates a series of squiggles, and all those squiggles mean things to us as cardiologists. So there's an initial bump. That's called a P wave. That is the top chambers of your heart. That's the electrical impulse that comes from the top chamber of your heart. Then you have that big kind of up and down squiggle called the QRS complex. That is ventricular depolarization. So that's the bottom, the muscular chambers of your heart getting that electrical impulse. Now there's a delay between the electrical delivery and the actual mechanical squeeze, but that's the relation there. And then there's a little kind of bump afterwards called the T wave, that is the recovery of the bottom chamber of the heart of the ventricle. Now, the upper chambers do recover as well, but they're just not as meaty, so you don't see that electrically on a surface EKG as much. If you're doing wiring inside the heart, you can see that. It's called an intracardiac echo, but that's a whole other ball of wax. And as we look at these intervals, as I mentioned, inside the wiring of your heart, you have different channels and different pumps that are pumping these electrolytes back and forth. As I mentioned, sodium, potassium, magnesium, calcium, these are the four that get pumped back and forth. And so if you have a calcium abnormality, that can affect the length of some of these intervals, like the time that it takes electricity to go through can widen out. So we look at things called a QRS interval or a QT interval. That's the space between these blips. Probably a little nerdy, but the point being is that these intervals are all affected by these ion channels, calcium, magnesium, potassium, and think of those are like bouncers at the club that let people in and out. So the sodium bouncer is the sodium channel, let sodium in, and then there's somebody that kicks out the potassium. It happens in milliseconds at a very small scale, but what we see not just with sex hormone changes, sorry, testosterone. What am I supposed to call them now? Now
Well,
I've got
now like
bikini
the new
hormones in my head.
terminology is PET because it's progesterone, estrogen, and testosterone. So you can say
Okay,
PET hormones, and then this is like I
this
guess
is
the way that we're kind of, I don't want to say it's being politically correct. I think it's just identifying that the hormones are important systemically and not just localized.
okay. So as you look at the effect of these pet hormones, they can actually slow down or speed up how fast these ion channels are letting these electrolytes in and out, and that can have effects on the EKG on the surface. But more so internally, what that can sometimes do is set up these kind of weird aftershocks. We call them early and late depolarizations and late potentials, where you can get like a if you've ever been like surfing or you hear a sound wave kind of bounce off and come back at you kind of fast, or you see a wave, so you can set up these weird electrical phenomenon that confuse the heart muscle, and cause them to beat early, and sometimes you can just get caught in the spin. So with these pet hormone changes, then as you affect the ion channels, you can get a situation where you have less potassium but more sodium than you'd expect, or magnesium is kind of like the calming, kind of, it's like the
Mhm.
aloe vera of the arrhythmia.
Aloe vera.
Yeah, it like soothes everything down. You get a hot sunburn, you put the aloe
Hmm.
vera on. And so you can get changes in these relative ion concentrations, these distributions, and that can then set up for these kind of early or late or sustained electrical impulses that eventually lead to arrhythmia. So it's a complex idea, but I think the idea here to extract and go back to the 10,000 foot level is variations in hormones, right? And these pet hormones can affect your heart rhythm system. And it's something that is not super well recognized. In fact, oftentimes the only time when I was in my conventional mindset that I would ask um, about hormones would be when somebody would come with palpitations. I guess maybe another time with chest pain, but I would say, well, is there any coordination of these palpitations with your menstrual cycle, right? And this is
Mhm.
when women are normally menstruating. Like, is it in your like before you ovulate, after you ovulate, like when you're about to have your period? And I would ask these questions trying to sound all smart. I don't know what to put it together, right? But at least like when you're setting these things up and asking these questions and framing it in a certain way, women will be like, oh yeah, you know what? It's funny. Like every few days before I ovulate, I'd feel this funny palpitation. Okay, well, I know that there's an LH and FSH surge, and so that may be something that's going on here. But I think it becomes even more interesting in this time of menopause, perimenopause, because now you're getting kind of wild swings of hormones. They may or may not be on a regular basis. And so, amongst many of the things that women are suffering, the vasomotor symptoms and
Mhm.
all these other things, now that you're getting palpitations on top of it, and man, you just feel like, man, what else could happen, right? Like what else is going wrong? But a lot of the therapies for this are kind of tried and true. I mentioned magnesium as the aloe vera. So one of my go-tos for these, benign palpitations. So this would fall under the annoying bucket, either fast and annoying or slow and annoying, would be to give people magnesium, and oftentimes we'd see a pretty significant decrease. I'd venture to guess in my practice, probably I'd say about 80% of people felt better. Not to say that eradicated, they completely went away, but they improved their symptoms of that early heartbeat or heavy heartbeat or sustained heartbeat. Because again, you're giving magnesium. Magnesium is kind of the chill out element. And interestingly, when you're stressed, you deplete magnesium, right? And so you get into this feed forward cycle where you're stressed because of the arrhythmia, and now you're depleting your magnesium, but now the arrhythmias are causing you to feel stressed, and you're depleting it again. So just something as simple as magnesium, super helpful. I do a lot of work with like sympathetic, parasympathetic tone, and so breath work becomes really important. Doing things like cold plunge, if that is something that is available to you. I grew up in Chicago. I hate being cold. So I don't love
Same.
cold plunges. I know that they're supposed to be therapeutic. Just for full transparency, I don't do them. But you can even just put your face in some cold water. When you're freaking out, what do they tell you? Splash some cold water on your face. That's that diver's reflex. It kind of adds that parasympathetic tone. But there's a lot of things that you can do, with palpitations. And I think particularly again, in the women dealing with menopause, perimenopause, there's so many other things at play. Electrolyte imbalances, stress,
Mhm.
right? Like sympathetic drive, adrenergic tone, thyroid abnormalities. Um, you know, uh, Above and beyond just the pet hormones being off. I like that. It rolls off the tongue, pet hormones.
Yes, and it's very clear. Like I'm
It
talking
is.
about three
It is.
specific hormones, and they're important for both men and women. And I so love how eloquently you described what an electrocardiogram demonstrates. And for listeners, the reason why I wanted Dr. Sanjay to explain this is that one of the ways that we as clinicians evaluate palpitations is doing an electrocardiogram or an EKG. And part of this is to screen out like really serious things. Like I mentioned earlier, I was seeing a patient in the ER and the ventricular arrhythmias went across the screen and it precipitates everyone moving very quickly to address said arrhythmia. But in most instances, most premature beats, whether it's a premature atrial contraction, premature ventricular contraction, in most instances, I emphasize most, these are benign entities. I will say the exception is when someone has multiple premature ventricular contractions. We used to call them couplets or quadruplets. Like when you see three at a time, four at a time, we start thinking about more serious things. And
I-
and typically this is someone who's being hospitalized. There was a very wise cardiologist that I worked with years ago. Unfortunately, he's no longer with us. Um, and his name was Dr. Robert Heron. And I want to give him credit. I was a new nurse practitioner, and he was very stern, but really invested time and effort in the nurse practitioners. And he was also an interventionalist, so does the kind has the kind of background that you have, Dr. Sanjay. And I remember him saying, Cynthia, I want you to think for the rest of your life when you see more than a couple PVCs, you think ischemic heart disease
Yeah.
until we prove otherwise. And so I always tell people that sometimes it can just be I had too much caffeine in the setting of low potassium, low magnesium, and I've precipitated these electrolyte disturbances. And in most instances, it is not ischemic heart disease, but important to just identify. There are times when it cannot be benign. It might be a sign of something else.
Yeah, that can be the canary in the coal mine, right? If you
Correct.
see a lot of those things, you say, "Oh, my spidey sense is up. Something.
Yep. Walks like a duck, quacks like a
There's
duck.
a shoe about to drop. Let's get
Yes.
ahead of this." So yeah, I mean, there's a lot of subtlety here. But one of the things I will say, I think we talked last time about agency and
Hmm.
returning, the ability back to patients to take care of themselves. And this is where I think wearables have been great.
Hmm.
I've had several patients who have had a watch-based device or a wristband that I thought would be completely useless, to be honest with you when they came out, but where we were able to diagnose and get them to therapy so much faster because they had the wearable device on. So, there's one that goes out there and it says it's like having my cardiologist with me all the time. I'm like, I don't know about that, right? That seems a little bit extreme. But these tools can be very useful and very helpful. And I think if nothing else, for reassurance that, nothing really bad is happening here. I feel like as a cardiologist, probably, I don't want to say, I don't want to overestimate, but let me say maybe 30 to 40% of the interventions I take are really just to help calm people down and prove that, nothing bad is happening here. I call it ART, aggressive reassurance therapy. So sometimes having a name to something that you're feeling, but knowing that it's not that significant, putting it into that slow and annoying bucket as opposed to the slow and dangerous bucket can be really helpful for your whole mental, emotional, spiritual balance, right? So I am a huge fan of those wearables, and I think that if you're suffering from these things, it's not a bad place to start.
Absolutely. And I think, the other thing to mention is that, some practices have specialized arrhythmia doctors. They're called electrophysiologists. And I worked with four in the large practice I was part of. And the one thing I can tell you about the EP physicians that I worked with, very cerebral, very serious, because they see the worst of the worst, and their jobs are to put in devices like you need a defibrillator or you need a pacemaker or you need an ablation. So they spend a lot of time in the lab. We used to call them lab rats. A lot of time in the lab, a lot of time looking for minutia for to kind of address arrhythmias or heart block, as you mentioned. And in some practices, cardiologists do both. They do general cardiology and they also do electrophysiology. So if anyone's listening and they're familiarized with an electrophysiologist, they are the detectives of arrhythmias and heart blocks, and they deal with devices and other specialized procedures. And they are the lab rats because that's where they spend all their time.
Yeah, I used to say they're the electricians, we were the plumbers as
Correct.
interventionists. But yeah, it's super um, subtle, I think, the
Mhm.
field, and they're the ones I mentioned before, these intracardiac echocardiograms. So now you're actually putting catheters inside the heart to map out the conduction system, and their ability to map that out unmatched. I mean, they would be like, "Oh my gosh, did you see that blip?" Like they'll be sitting there for 20 minutes, staring at an EKG go by, and one extra blip will come. And they'll be like, that was the key to the case, right? It's like watching one of those murder mystery shows.
Ectopic
Oh yeah,
foci.
I can see the shoe print matches the shoe of this person, and it must be, Mr. Plum in the closet with the candlestick holder or whatever, right? I mean, they are smart people when it comes to the arrhythmia stuff. But yeah, that would be, ultimately, it doesn't necessarily mean that you always need an
Correct.
electrophysiologist for these palpitations, but they're the ultimate end user and
Detectives.
treater of these sorts of electrical issues of the heart. Yeah, absolutely.
Yeah, I knew that I was not going to be an EP nurse practitioner when I sat in on a couple cases, and I was like, I can't stand in one place all day with lead on. I just felt like by the end of the day, I was like shrinking because
Yeah, well,
the lead weights that you wear to protect yourself are very heavy, as I know you know. But
yeah.
by the end of the day, I felt like I had shrunk by about 3 inches because it was just, it was
Probably did. They need to like hang you upside down like an inversion table or something in the labs. But yeah,
exactly, exactly. So when we're talking about palpitations, evaluation, let's talk about atrial arrhythmias because I think in many instances, and for listeners, we have two atria at the top chambers of the heart, and that's what we're going to start with. Let's start with like really benign and go all the way to like fibrillating atrial arrhythmias.
Yeah. So the most common benign arrhythmia would be what's called a sinus arrhythmia, where just by breathing, you're changing how much blood is coming into and out of the heart. That changes the stretch on the top chambers of the heart. So you can see a little bit of a variation. That is normal physiology, but sometimes people will have an EKG done and
They
they say,
freak out.
yeah, it's not completely on time. And I said, no, that's great. That shows that things
Mhm.
are working really well. So that's normal. Then you can have what are called premature atrial contractions. These names are very descriptive of what they are. Premature early atrial from the top chamber of the heart contraction squeeze. And so that can be a situation where you would expect the beat to happen in a certain order, and one comes, a little bit before. It's early, right? That's premature. That's again a very benign arrhythmia. Some people will feel that though, and you can be aware of that. And so that, as I mentioned, the distress of feeling it can oftentimes drive a lot of anxiety. But again, not a big deal. Nothing that we treat. We just say have a Coke and a smile and just relax. Maybe not a Coke because we don't want the caffeine. And
Non-caffeinated
yeah,
beverage.
a non-caffeinated, have a non-caffeinated kombucha and smile. And then the more serious would be atrial fibrillation, and so this is where rather than having one dominant area of what we call pacemaking cells, or one dominant area that's telling your heart to beat, you have hundreds, if not thousands, of areas, and so this is a chaotic milieu. I kind of think of this like a room full of toddlers just running around hopped up on Halloween candy, right? Just kind of everywhere. And what happens is electrically, these waves will sometimes come together and crash and cancel each other out. Sometimes they come together in phase and they add to one another. And so they send this really chaotic series of electrical impulses to the bottom chambers of the heart. The bottom chambers are just like the worker bees. They just do as they're told. The top chambers are really the managers of the situation. So anytime there's a strong enough electrical impulse sent from the top down to the bottom of the heart, the bottom chamber beats. And so that's the fibrillation, is this irregular aspect of beating. Now, in and of itself, a couple of problems with the ventricles is that sometimes when you're beating in this irregular pattern, they don't have enough time to fill, so they can't push enough blood out. It's like trying to breathe rapidly through a straw, so you're going right? You're not really getting a deep breath. You're not getting adequate gas exchange. So people can feel lightheaded or dizzy or kind of clumsy. Particularly, this is a rhythm that happens as we get older after the age of 60. It increases by 10% prevalence every 10 years. So as we get older, you may have more of these sensations and your ability to tolerate them becomes less and less, just like, our ability to tolerate anything as we get older gets less and less, right?
Mhm.
So people can become lightheaded and dizzy, and this can be a problem. Um, so in the top chambers, now remember, you have these thousands of electrical impulses happening, and what happens is the atria, the top chambers, cannot beat that fast. They can't beat thousands of times a minute. So they come to this kind of very tense standstill. And what happens is they're just kind of contracted and not really moving. And as a result, you're not able to wash the blood through, right? You're not getting
Mhm.
movement. And so what happens when blood just kind of sits around? Well, it starts to clot, and that's where clot risks come from. So that's why when somebody goes into atrial fibrillation, we'll make a calculation, so we call it Chad's VASc score, to see if you need to be on a blood thinner to prevent the risk of clot, because that is oftentimes the most devastating aspect of atrial fibrillation, is not the arrhythmia itself, but a stroke. Somebody probably 50% of the time, people who had stroke, that's their presentation symptom or presenting symptom of atrial fibrillation that was undocumented. Um, and the other question, and what I forgot to mention about the bottom chamber, is sometimes people don't feel it at all. Sometimes it's just sitting there buzzing in their chest and they're not aware of it, which if you're a patient, that's a blessing because you're not feeling your heart beating all the time. But from the doctor's side, it becomes a little bit more difficult because we don't know how long you've been in the arrhythmia, right? So some people will say, oh yeah, on Tuesday at 11 a.m., I was watching The Price is Right, and boom, all of a sudden my heart felt funny, right? That is a great situation for the doctor because we know exactly when this happened. But people may have been in AFib for weeks or months. They don't feel it until they happen to get an EKG at a check, or they happen to have a doctor listen to their heart and say, "Hey, I've never heard this before." So it can hide in plain sight. Oftentimes, it doesn't need to be symptomatic, but that's why getting routine checkups becomes so important.
Absolutely. And this is where like taking a good history, doing an EKG. In some instances, we have 24-hour heart monitors. If someone's saying, I get episodes every single day, then a 24-hour monitor is reasonable, called a Holter. Event monitors are longer, up to 30 days, like you mentioned, that patient that you had, which can be helpful. In terms of lab work for you, kind of high level, what are the labs you're looking at to help evaluate palpitations by history? And I think these are pretty straightforward, from my perspective. But I think for listeners, if they're going to their internist as a starting point, what are the things that I think are most, or what are the things you think are most important that they should be following up on?
Yeah, so I think first electrolytes, you'd mentioned that several times, and we've talked about that before. So getting what's called a complete metabolic profile. That's not just looking at kind of the basic sodium, potassium, but it looks a little more deep. Calcium, magnesium levels, I think, are very important as well. Now, the thing about magnesium is it can be normal, but you can be
Hmm.
addicted. It's like having all your money in your checkings account with no savings, right? So if there is a lot happening, you have to look a little bit deeper into something called RBC magnesium, which is a better idea of how much you have available as storage. You can almost never get in trouble. I mean, I'm saying almost, right? Never get in trouble with just repleting magnesium.
Little bit of diarrhea and it goes away.
Yeah, I mean, 70 to 80% of Americans are deficient in magnesium anyway. So oftentimes, I would bypass a check, but that's because I'm kind of a practitioner. All the silver highlights in my hair, right? With experience gonna allow me to do that. But if you're not sure, you're a younger patient, you can do an RBC magnesium. Certainly thyroid has to be a part of that evaluation as well, because low thyroid or high thyroid, so either hypothyroid, low thyroid, or hyperthyroid, high thyroid, can activate arrhythmias and cause a lot of craziness to happen. Looking at stress levels, so cortisol levels, that can, if somebody's really in a sympathetic storm, or this is where we start asking about what's going on in your life. Oh yeah, my house burned down, my dog ran away, my pickup truck broke, and I thought I won the lottery, but I lost the ticket, right? Like, all these kind of stresses that happen in old country western songs. I mean, that stress
Hmm.
load can precipitate these arrhythmias sometimes as well, particularly the more benign arrhythmias. So asking about that. From a lab standpoint, and then basics, just looking at a blood count, making sure nobody's ischemic or sorry, is anemic and has inadequate blood flow that's causing ischemia to the heart. I mean, those are options. And then from there, the further testing is really directed by what type of arrhythmia it is. You'd mentioned ventricular arrhythmias that come from the bottom of the heart. Those tend to be more insufficient blood flow oriented. Atrial arrhythmias from the top tend to be, I think, a little bit more hormonally mediated or stress mediated. So, it's not a one size fits all, but yeah, generally complete blood counts, looking at electrolytes, metabolic profile, and thyroid are at the very least what you should do.
Absolutely. I also think about there's something called a cage questionnaire. I'm not sure if people are
Oh,
still using this, but patients, I would ask them how much alcohol, and you ask in a non-judgmental way. But when they would say, "Oh yeah, I have like 3 or 4 drinks a night," we used to just double whatever patients would tell us. So if a patient was hospitalized, I would oftentimes check an ethanol level, like looking at their alcohol level, because I would see an uptick in atrial fibrillation in particular around we used to call it the holiday heart. We
honey
knew
heart,
around New
yeah,
Year's,
yeah.
Christmas, grandma had a little too much to drink, or grandpa had a little too much to drink, and they would present with new onset or chronic AFib that was, higher than the normal pulse rate than we would see. So thinking about other things that can precipitate arrhythmias, I'm also thinking about like untreated sleep apnea or
So,
inappropriately treated sleep apnea. I think for a lot of people, like my husband is a healthy weight, and we used to walk into patients' rooms and we would ask what their neck size was,
hmm,
applicable to men, not necessarily women. And if their neck size was greater than 17 inches, we would automatically start asking questions about the potentiality of sleep apnea. And we know untreated sleep apnea can worsen high blood pressure, put you at greater risk
absolutely.
for heart disease, put you at greater risk for arrhythmias.
Drop your testosterone, all the things. And yeah, I like what you said there because it's no longer, we used to call it truck driver neck in Indiana where I was in school, but it's no longer truck driver neck. You can have thin people. And I think a lot of this is, from the mouth breathing and we're chewing softer foods and we don't have the same tone. And in fact,
Mhm.
there's a device out there that's basically a pacemaker for the muscles of the pharynx and the hypopharynx.
You got
Uh,
a floppy pharynx.
yeah, that it's an implanted device that increases the tone at nighttime. It seems like a crazy extent to go, but if you have severe sleep apnea, then that may be your only option. But yeah, there's a lot of things out there. But yeah, I do agree. Sleep apnea is a huge precipitant of atrial fibrillation as a cause.
And that can also happen in women. I just did a podcast with Dr. Matsumura, who's a sleep specialist, and she was talking about how progesterone in particular can be a precipitant for putting us at greater risk for developing sleep apnea as we're navigating that perimenopause to menopause transition. Makes complete sense because it's, smooth muscle in our airways and elsewhere. And
Yeah.
I was like, of course, we're going to be at greater risk for sleep apnea as we're getting older.
I mean,
Um,
it's just menopause sucks. There's no way. There's no
men, andropause is not nearly as dramatic. I think you
yeah.
guys kind of go through this like
You
slow
just
and steady decline, and we kind of drop off a cliff, and then we're expected to pick up the pieces.
Yeah, that's how did women even survive, right? Like if you think about it, like
I
anyway,
think, duct
that's
tape
a
and
question
bubble
for a
wrap.
different podcast, I'm
Yeah,
sure.
for sure. Okay.
Yeah.
So we've gone through kind of the trajectory of how you evaluate patients. Let's talk about ways that you address palpitation. So let's start with your algorithm of annoying and benign and kind of work our way down because I think we got so many questions around this. I think in many instances, people get an appropriate evaluation. I'm not being critical of having the evaluation, but I think a lot of people don't love the way they feel when they're on as needed medication or chronic palpitation addressment chronic medication to address palpitations. Let me just rephrase that because I was like, what is that? What just came out of my mouth? Let's talk about how you address it from a pharmacologic perspective.
Yeah. So, the first thing first is really understanding the why, like what is precipitating the palpitation. I think of this one woman who came to me with palpitations, and I don't know if I talked to you about this last time, but I just asked for some reason, like the universe just kind of struck me and I asked the simple question, do you feel safe? And she's like, what do you mean? I'm like, I don't know, just do you feel safe? And she goes, actually, not really. And then she launched into this whole
Um,
thing about her husband and her partner, whatever I'm supposed to say, and kind of a not great situation and all these things. And the easiest thing for me would have been to just give her a beta blocker and just but there's just something that struck me weird about the situation. So I think first of all, understanding the context of what's going on in someone's life and perimenopause, menopause, andropause, all these things aside, right? Like what's going on, right? What are the things that are weighing you down? Do you feel stressed? Are you stuck in, I call it the caregiver sandwich, where we're taking care of our aging parents and our, stupid teenagers that need to age up a little bit more, right? They're doing dumb things. And you're
get
just
with the
kind of,
program.
yeah, and you're just kind of caught in between, right? So that happens a lot to any of us, right? In that 35 to 45, 50 age group, let's just call it. And so really kind of understanding, are there things that we can do to implement there, right? Is there like maybe I can have you do a breathing exercise for 20 minutes a day and kind of give you that relaxation. Maybe you need to extract yourself from a bad situation like this woman did, right? Because no amount of medicine for her was going to solve the underlying issue, which was not feeling safe at home, right? That's one of those core foundational needs. So first off, figure out where the patient is in their life, what are really the precipitants, what are really the drivers of the situation, and then go towards the medical things, right? Okay, if your thyroid is high, thyroid is low, let's fix that. If your electrolytes are off, let's do this. Again, one of my go-tos has just been magnesium glycinate. I think you can get into very little trouble with magnesium. You had mentioned, yeah, if you take too much magnesium, you might have a little runny poops. And, if you really have too much, you get a little bit weak, but that's almost like in an IV kind of really high dose situation. Like when we have women that we have to arrest their contractions in OBGYN, we use IV magnesium. But outside of that, very little downside to taking magnesium. Then for most people, that just gets them better. Certainly doing a monitor or trying to capture the phenomenon of what's going on. I mentioned several times where I thought something was benign and something ended up being more, malignant, right? It went from that annoying to that dangerous, and that kind of changed the algorithm of what we needed to do. But really kind of sorting that out. But magnesium, again, you can't go wrong with that. I think for most people, a lot of it is just getting outside in nature and doing walks, just kind of decompressing, just kind of releasing some of the air out of the balloon, is super helpful for, again, the benign arrhythmias that are kind of exacerbated by stress. Now, when we talk about the more malignant things, so the top chamber tends to be very more benign. The bottom chamber can be a little bit more malignant. So if you're having episodes of, as you mentioned, runs of these ventricular tachycardias, we call that non-sustained ventricular tachycardia. You're having, certainly if you're having VFib, ventricular fibrillation, very different than atrial fibrillation. That's a
One
cardiac
you're kind of
arrest,
dead.
right? Yeah, one you're
One
kind of
you're
dead, one you're
dead.
kind of just lightheaded.
Yeah.
But again, those would precipitate evaluations of insufficient blood flow to the heart, or sometimes you can have cardiac inflammation, like in a post-viral situation, a myocarditis. I've seen that, particularly in these last few years,
The
kind
hearts can
of
be
as well.
irritable. They're
Hearts
kind of
can
like
be irritable,
cranky.
hearts can be inflamed and cranky. And in fact, there was just a scientific statement released by the American College of Cardiology on inflammation and cardiovascular disease, where they specifically called out pericarditis or inflammation around
Mhm.
the heart as a something. So there's a lot of different things. I don't know if I completely answered. Oh, and then as we go to the more pharmacologic kind of therapeutic things to do, then we engage in some more conventional medications, things like beta blockers, which are medicines that help slow your heart rate down. They do drop your blood pressure. And the idea is that by slowing your heart rate down, again, these medicines will affect those ion channels. Now we're making those early beats less likely to happen. And so you can treat arrhythmias that way. Sometimes you do need to go in. We mentioned the electrophysiology doctors. So if there are areas like little rogue spots in your heart that are causing these early episodes to happen, or little short circuits inside the heart where the wiring kind of bypasses the normal conduction system and is leading to early beats, they can actually go in and zap those out. In fact, my father-in-law had to have that done. He was having something called a premature ventricular contraction, which generally is benign, but he was having about 30% of his all
Wow.
beats as PVCs, and over time that can actually lead to weakening of the heart muscle. So a buddy of mine did a PVC ablation. It was amazing. One little zap, like
Yeah.
on the spot, one little, less than 2 second zap, and he's been cured. And that was probably 7 or 8 years ago. So it's really remarkable what they're able to do. But it can range from something as simple as balancing your life to balancing your electrolytes to going in and getting an invasive procedure. Again, it depends on what's needed in that situation.
Yeah, and I love that you touched on the lifestyle piece because I don't think there's enough conversation in traditional kind of allopathic models of how impactful stresses and lack of sleep. And to your point about electrolytes, I used to, in the hospital, I always say, like, I'm the queen of electrolyte replacement because so much of my job was about that, either orally or IV. And so obviously in the hospital, we do IV medications because generally it's just easier. We know that I have a pretty narrow perspective of where I like to see potassium, where I like to see magnesium. To your point, for anyone listening, you need a red blood cell magnesium. The other magnesium is not as accurate depiction of intracellular magnesium levels. And I cannot tell you how many patients we couldn't get their potassium. And this is back when, we didn't know better. Couldn't get their potassium therapeutic, and it was because their magnesium was also low. So you need both. It's like peanut butter and jelly. You need to check both. The great thing about magnesium is the worst thing that's going to happen. This is why I never sweated it out. I was like, the worst thing that's going to happen if you have too much magnesium, you'll have loose stools, and it's self limiting, meaning when you stop the magnesium, it goes away. So that's a temporary thing. It's pretty hard in an outpatient setting or orally to take too much potassium. Obviously, the really hardcore potassium is kept in the CVICU, ICU environments. That's generally not on the step down units or accessible to most healthcare providers. I love that you talked about replacing thyroid if that is warranted, correcting iron deficiencies, which can sometimes precipitate things, really looking at inflammatory markers, thinking about beta blockers, calcium channel blockers, antiarrhythmics, excuse me. A lot of these drugs, especially if you have atrial fibrillation, we really want to get you back to normal sinus rhythm. Like that is the goal, like control the heart rate, get you back to normal sinus rhythm. Sometimes that's done chemically, sometimes that's done with a procedure, probably outside the scope of this kind of podcast interview, but that is clinical decision making made with the cardiologist and or electrophysiologist, so beyond the scope of kind of a general conversation, but just to let people know there's different ways that we can address this. Also, managing your weight, eliminating alcohol, addressing sleep apnea, all really, really important. I think that when I'm thinking about how to evaluate palpitations. We talked about red flags. We talked about the things, obviously, some things, if you pass out, if you're dizzy, you get into a car accident, that's more concerning than someone saying, I had 5 Cokes today
Boom, boom, boom.
and,
Yeah.
and I feel like I'm having palpitations. How about patients that present with supraventricular tachycardia? So something that's above the atrial, like at the top chambers of the heart. How do you like to address that? I know we haven't touched on it, but I did get a couple questions from people who I guess have had this by clinical history. How do you
Yeah.
like to address SVT?
Yeah, so there's the atria, right, in the top chamber, and there's the ventricle, and in between there's a little thin strip
Hmm.
of conduction tissue called the AV node. And in there, I mentioned short circuits. So sometimes you can have short circuits in there, or you can have short circuits called bypass tracts in that
Hmm.
kind of thin demilitarized zone between the top and bottom chambers of the heart. And those are interesting, actually, depending on what happens. You can sometimes even just do something as simple as a carotid massage, increase vagal tone that can get people
That
out
needs to be done in the hospital
in the
or the
hospital. This is not a
office.
DIY. Don't
Don't
watch
do this at home.
YouTube. Yeah, don't do this at home, but there are things that you can do, and that's a temporizing measure. But ultimately, that is a great place for the electrical doctors to go in, map out the conduction circuitry of the heart, find out where this, we call it a bypass tract, so find out where this abnormal connection, the short circuit is, and then zap it out. So that's something. But the rhythm that you feel there is you're just sitting there. And it's like the all of a sudden, doc, I just felt my heart buzzing in my heart, in my chest. And we did talk about this, but the speeds of the heart can actually give us some sense of what the rhythm is, right? So we didn't talk about atrial flutter at all, which
Yep.
is which is
Sawtoothy.
another rhythm that can happen on the EKG. It looks like a sawtooth, and generally that's going to be at about 140 to 160, 180 beats a minute, maybe. But when you're getting past 160 into that 160 to 180 kind of 200 zone, generally that's going to be some sort of a supraventricular tachycardia or a bypass tract. So there's, again, a lot of different ways that we look at this, a lot of different inputs that we get. But yeah, if you're having a supraventricular tachycardia, that can be precipitated by hormonal fluctuations. Again, in that conduction system, you're getting the ion channels, changing in their affinities, and so you can get these microcurrents and things that can happen. But generally, that would be curative with an ablation. In fact, a girl I dated in college, she had an ablation for SVT. I didn't know what it was. I was like, "What? They go through your leg and you know, they fix your heart?" And I don't think that's what made me want to be a cardiologist because that relationship didn't work out. But it was interesting to see, oh wow, that's really cool that you can do this. And the cure rate, meaning that, once if you have SVT, when they go in and unless there's
Much better.
losses, it is remarkable. Right? It's
Yeah.
life-changing. There's one woman I had who I tried to convince her for 4 years to get an ablation, and she was just nervous, which I totally got. I said, okay, well, one day you'll come to me
You'll
and
be ready.
you'll be ready. And so about 4 years later, she had a pretty bad syncopal event where she went down and stuff in her church, and so it was kind of scary. So she got the ablation, and now it's been like 7 years, and she has not had another episode since. And it's
Amazing.
great when you can actually fix someone, right? So
Absolutely.
she did
Absolutely. And it's funny
really
that
well.
those supraventricular arrhythmias, some of the things, because I would sometimes come down to consult on patients before my docs who are probably in the lab or somewhere else. And I would say, okay, let's get you to bear down. So pretend like you're increasing intrathoracic
Yeah.
pressure. It's one of the ways you can, stimulate the vagus nerve. There's a variety of different ways that you can do that. But for some patients, just bearing down or coughing or humming. I mean, sometimes it would be something as benign as that. They kind of taught themselves, like, oh, when I feel this, because it's happened so many times, this is what I need to do to get me out of supraventricular tachycardia. Again, I always say, like, if you've never done that before, don't do that on your own. Do it in the company of a licensed medical
Price,
provider.
yeah, absolutely, absolutely. And again, the other thing about the other thing about arrhythmia, my brain is working
Hard to
faster
spell, hard to say.
faster than my mouth, which happens a lot. But let's not forget about the lifestyle component to arrhythmias, right? And as we
Mhm.
look at these ion channels and mitochondrial dynamics and things like that, is that when we are inflamed, when we're in a lot of oxidative stress,
Mhm.
right? These are things that precipitate cellular dysfunction that lead to ion challenges or ion imbalances that can lead to these electrical things. I just did a whole talk for A4M a few weeks ago about the role of oxidative stress
Mhm.
in a variety of cardiovascular conditions, but atrial fibrillation and arrhythmia in particular is when you're really inflamed, when you have a lot of oxidative stress, when you have a lot of peroxynitrate and superoxide and all these things going on, that directly affects our cellular function and that can precipitate arrhythmias. So oftentimes you're living la vida low inflammation, right? You're low inflammatory and getting your fish oils and all those things. That can actually make it less likely, if it's going to happen, it can actually make it less likely for it to go down. So that speaks to the importance of not just dealing with these arrhythmias and lifestyle issues when it's already happened, but living the right life, eating the right foods, having the right behaviors, all of these things can protect you from having to develop into these arrhythmias over time.
Well, and I think that's really important because it all starts with lifestyle. And I think for a lot of people, maybe it's been over the last 5 or 10 years that we're hearing more of this, how important lifestyle measures are for maintaining health. I love to touch on one more topic, and I recognize that some of the questions that came in were very specific. So we're trying to talk in generalities, and then people can take the information back to their providers. I got a lot of questions around athletes that are women, as well as specific genetic propensities for arrhythmias. Do you feel comfortable kind of identifying, like, if you are meeting with a new patient as a cardiologist, things that would be specific to a past medical history or family history about arrhythmias that would be a flag for you to think about someone probably needs to escalate their care in terms of going directly to electrophysiology or involving electrophysiology in the discussions that you're having about the plan of care for a patient?
Yeah, I mean, so in general, arrhythmias, we don't see a huge signal that they are hereditary, but there are some hereditary conditions that can cause arrhythmias, right? So it's like not all things orange or oranges, but not oranges or whatever, you know what I'm trying to say. So there are some, so you can have what are called channelopathies, so ion channel abnormalities. We've mentioned these several times, but genetic ones that can predispose you. There's things like what's called long QT syndrome or short QT syndrome that are at play. There are certain bypass conditions that can be handed down, meaning short circuit conditions, like there can be some Wolff-Parkinson-White
Yep.
and LGL, which is another bypass track that can happen. So if you have a family history of people passing out or suddenly passing out, I'll always ask, do you have a family history of anyone who died suddenly?
Yep.
Unexplained. Like they're just like you hear these stories of the kids at sports practice, and all of a sudden someone goes down and they
Very.
CPR. So do you have a family history of that at all, or have your parents ever had passing out spells before the age of like 60, 65 or so? That can lead to thinking about these sorts of things. Any inherited or any abnormalities on their EKG. Like when I get an EKG, first question is, did your parents ever say they have funny looking EKG? That in probably not politically correct now that you can't say it or you can say it now, but like in the 90s when I went to med school, I was in on a pediatric rotation with a geneticist, and he said, when you have someone that looks syndromic, that's what we would say, you always have to look at their parents first
Hmm.
and see if they just look like their parents, because they could just look
Right.
like their parents, right? So if you have a funny looking EKG, do your parents have a funny looking EKG, right? That can be a metric. For the athlete in particular, you have to ask about the type of activity and what's happening. Like I'm a lifter, so there's all these powerlifting videos where these guys are trying to lift 1,000 pounds and they just kind of pass out. That's not really an arrhythmia. That's just they were just holding their breath so hard, their
Hmm.
hearts they couldn't pump blood through. So that's called like a vagal episode, I guess.
Yep.
So they're just kind of bearing down so hard. So that's not generally going to be something. But if there's like a runner right? Someone doing endurance work that they tend to have palpitations at a certain point in time, or in the family they have it. That could be something of interest. A little fact: the most dangerous mile of a marathon. Do you know where that would be?
I'm guessing the
I mean, it's
end.
26.2 miles, right? So they're kind of all dangerous, but it's the latter third is
That's what
actually
I figured, the end.
right? So miles 18 to 26, because why? Because that's when you're sweating out, you're getting electrolyte imbalances,
Hmm.
you're drinking water more than you're drinking sodium in, so you can get low sodium. So that last third can be where a lot of these arrhythmias happen. So that oftentimes they'll have more aid stations and medics kind of at that point in a race as well. So, so asking, okay, you're an endurance athlete. Does that mean that you're like a 5K runner? In which case, probably not a big deal. Are you an ultra marathoner where you're going 50
Mhm.
miles? Oh, that's a something, right? Do you run a marathon distance? So sorting out exactly what sort of athlete they are. Sprinting. So if you're someone who's like doing basketball or football or soccer, or something like that, you tend to again have this at the end of the episode, at the end of the sporting event, as opposed to during the middle, unless there's some sort of arrhythmia that some sort of a structural issue that's precipitated. So again, it's tough to say, and it's kind of speaking generally, I'd have to say, well, it depends, which is kind of the worst answer to have, but it really does because there's so many nuances because someone who's shooting, archery is a very different athlete than someone who's doing the hurdles. So you just have to take that into account and figure out, I guess the questions would be when in the activity is it happening? Is it consistently happening or is it intermittent? Does it happen in practice or is it in competition only? Because there's tend to be people a little bit more
Mhm.
nervous during competition. And how long has this been happening? Is this something, that just happened in the last 2 weeks, or is this something that's been going on for years? And generally, with that framework and understanding what type of sports they're playing, we can figure out, okay, this is probably the type of arrhythmia that's happening, and then we can get them on an appropriate monitor because if you're a runner, we're not going to hook you up to all these wires or little stickers that we can put on your chest to give us an idea. I live in Southern California, practice here. We have a ton of surfers, so we had to find like a waterproof option. We had to put a patch over the device so that they didn't fry the circuitry. But there's ways that we can sort that out. So I wish I could be more specific, but that's about as good as it gets, I guess.
No, no, no. That was really helpful. And I kind of didn't ask ahead of time if you felt comfortable kind of giving that kind of broad base. But in all honesty, we get a lot of questions about these things. And I'm like, listen, I'm not seeing this anymore in clinical practice, but we can speak from a broad perspective. But obviously, if you have concerns about genetic propensities for passing out, sudden cardiac events, inherited EKG abnormalities, this is an excellent opportunity to connect with a cardiologist and or an electrophysiologist.
Yeah, and they can do genetic testing for
Mhm.
this, right? And so you give a blood sample and they can check and see whether you have this gene or that gene. And the one note on that is when we're doing for example, like a calcium channel issue or sodium SENC5 or whatever, sodium channel, we know what we know, but we don't know what we don't know, right? So we might know the most common 10 or 20 genetic variances or SNPs they're called that lead to a channelopathy, but there may be others that we don't know, right? And so I've had this several times with the gene testing where somebody will say, well, the test said I don't have it, but I have all the symptoms of it. And I said, well, we might just not know exactly what your variation is leading to this, but you may still have the condition. We just don't have the right question to ask yet. So it's very nuanced, but again, that is not something that you watch on YouTube or you go to,
No,
labs by yourself and get it done. There you need someone to help counsel you, genetic counseling, a clinician who is comfortable in ordering the proper tests for this, because believe it or not, sometimes people come to me with second opinions and I'll be like, boy, they didn't even order the right labs. Like what? Like, they're not even checking for what they thought they're checking for. So you really need to have someone who is conversant with these genetic tests, and generally a good electrophysiologist. These guys and gals are awesome at this. But ask, like what are the genetic things, and see if they're comfortable. If not, go to an academic center or seek out someone in your community who does do a lot of these sorts of. And there's message boards and things online that you can find physicians that are comfortable with this that other people have used. But that it's a really intriguing area. It doesn't come up very often, but like in one week, I remember I had like 4 or 5 different individual channelopathies, and it was just channelopathy week at my practice. It was weird, but it can happen.
absolutely. Well, as always, a truly invaluable conversation. Please let listeners know how to connect with you outside of this podcast, how to learn more about your work, or listen to your podcast, for which I have been a recent guest.
Oh yeah. So number one, I apologize for the nerdiness of this.
Yeah,
Super
but
nerdy.
people have been asking for this in particular. I think we had multiple requests just last week. So I was like, serendipitous. Guess who I'm
Perfect.
bringing on? We'll talk about it.
Perfect timing. So you can find me. So my podcast is called The Curious Cardiologist. It's on all the podcast places. So look me up. If you want to find me online, my handle is at Dr. Sanjay MD. So DoctorSanjay MD, because nobody can spell my last name.
Can't
Uh,
pronounce it either.
and my website is lagunamedicine.com. So www.lagunamedicine.com. My practice is called the Laguna Institute of Functional Medicine. We focus mostly on cardiometabolics, but all aspects of cardiology are at play. And I'm actually launching a telehealth program as well. So if you want to work with me one-on-one, for right now, just working with folks in California, but soon expanding everywhere. So reach out, fill out the forms, and I'll be happy to try to help fix whatever else is going on with you.
Hey, if you like this video, you guys are going to love this video, and I'll see you there.
The conversation I'd love to have with every 35-year-old woman is that once 40 hits, your ovaries are gonna be done, and they're gonna slowly, it's not like it's done overnight, they're gonna slowly decline. It's gonna take 10 to 15 years for these ovaries to be out. But you literally have an organ that is done doing its job. It'd be like if your heart was like, hey, I'm done. I'm just going to slowly like this. I don't understand why we don't talk about this.
Right.